Start now. Assalamualaikum and a very good afternoon. I greet to Dr. Faisham and all of my fellow friends. So today we're going to present about child with respiratory distress. Okay, and next. Okay, in this presentation we're gonna talk about asthma, croup, and respiratory distress syndrome. Okay.
Just to let you know, host lah. Is it who's presenting here? Who's presenting? Maisara. Okay.
Yeah, Maisara.
Yeah. So Maisara. I basically we're not going to be able to cover every single thing, but the most important thing is to understand the concepts of it. Okay. Concept of what it is, and maybe to improve on that. Okay, maybe to improve on the understanding, because you're just starting your what you call your rotation here. So it's not about one is try to improve on the basic, which is the history, physical examination, as assessment. Management, I think I leave it. You can read a little bit, but that's not the main emphasis here. So the main emphasis here is try to improve on the history, improve on the physical examination, the finding, expected findings, and a little bit about management. Okay, but how you should be able to make a proper assessment as a year three, isn't it? Your year three students. So that's the most important thing. I think the key there is try to improve on the basic understanding for pediatric, rather than going for year 5 kind of knowledge. And gradually you should be able to understand and improve on it from time to time. Okay, so at the same time, selection of the cases here, although it might not cover certain important or common diseases, it is also essential for you to be aware that you also need to read other topics related to other than the one that which is going to be presented. So other topics, for example, like you're doing asthma now, we might not discuss about bronchiolitis or pneumonia or chronic lung disease or something like that. So but still, your task is to be aware and understand every single bit. Okay. If somebody comes late by quarter past, since we started at 12:30, even 15 to, I'm not going to admit you guys. Okay, I'm sorry to say, you should be coming on what you call on time. If you're coming late, better not coming. Okay. So 15 minutes after that, I'm not, because I'm controlling it. Okay. Thank you very much. Okay, off you go, Maisara.
Okay, doctor. So this is the patient's ID. The name is Vincenzo Casano. The age is 3 years old, and he is a boy. The ethnicity is Caucasian, and the informant is the mother. Okay, we're gonna start about the history taking. For the chief complaint, he came to the hospital with complaint of coughing for 2 weeks, and for the HOPI, the cough is present every night. And initially, the cough improved after taking medicine, but it is worsened over the past 2 days. The cough becomes worse during strenuous exercise, and the cough relief with drinking water, and there is presence of sputum. And the associated symptoms are fever and nasal congestion. For the fever, it occurred for the past 2 days, and it is low-grade fever, and was given paracetamol as medication, and the fever subsided after a few hours. For nasal congestion, he sneezed in the morning, and there is runny nose. And actually, he has had similar episodes in the past, which is coughing, fever, and nasal congestion. But this episode is worse now. Okay, next.
Stop. I mean, okay, I know you. Go back, please. So if I ask you, what's the reason of her admission this time, or that she presented to outpatient?
He was presented to the outpatient.
Okay, so outpatient. So the reason for because I mean the title is asthma. So you say, I mean, so he presented to outpatient with the cough for 2 weeks. Okay. Number one, if this is asthma, what are the other history of asthma here? Asthma history apart from cough.
The cough is present every night,
Okay.
and
Anything
also
else?
he sneezes in the morning.
Okay, that's a different thing. Okay. Anything else?
But the cough becomes worse during strenuous exercise.
Okay. Strenuous exercise. Anything else?
When he was taken the medicine, he
When,
improved
what
initially.
time? I mean, what time? Is it at night only?
The medicine
No. The symptoms.
at night, the cough
And
occurs
then what about
heavily.
during the daytime?
The cough during the day, the cough appears when he doing strenuous exercise.
Okay. Anything else? Any trigger?
I don't know.
You're talking about asthma here, isn't it?
Yeah.
Okay. So what else do you want to know? We want to quantify the asthma severity. What else you want to know? Asthma severity.
Whether there is SOB?
Okay, SOB. Okay, yeah. You didn't tell me about SOB, yeah? Isn't it? Oh, is there any SOB? Any problem with the breathing at night?
For this case, it was not stated.
So anything else? Does he awaken him at night? Did he have to did he disturb his sleep pattern at night? Coughing saja, did he sleep his sleep pattern or not?
How many pillows he requires to sleep?
Below maybe not. I mean, this is a child, 4-year-old. Yeah, it's not going to be pillow. This is heart failure pillow. So it's not. I mean, like it's more related to what are the trigger factors. What are the symptoms related? So cough at night, that nocturnal. Where is it improve or not? Diurnal variation. I want to know. Does it improve during the daytime or not? I mean, you want to describe it as typical asthma lah. I don't want atypical. Atypical asthma, diurnal variation. But I mean, 2 weeks. Does that mean asthma?
Not really.
So what are the history that you have to take?
The family history.
No, asthma. It must be recurrent. It's not only one off like this. If it's one off, it's not going to. So previously, has he had an episode similar like this? How long? I mean, is it just these 2 weeks? Has it been for a year? Has he been presented to GP for nebulizer? Has he been coughing for it? So asthma must be recurrent. It's not one off. You're telling me it's just only one off history, but I don't know. Maybe this is another episode of recurrent episode. Maybe he had an episode, about 2 weeks ago, and then maybe he had previously last month. So asthma should be recurrent. It shouldn't be one off. So if it's one off, it's not going to be asthma. We're not going to diagnose asthma. So number one, the history should tell me that this is a chronic disease, and it should be recurrent lah. Okay, well, you say that this is 2 weeks. Okay, of note, for the last a month, I mean, he's been visiting the GP and requiring nebulizer. That sounds asthma straight away. If it's just only one off like this, I wouldn't take it as asthma lah. I wouldn't, because it's just only one off. Okay, so what are the previous history to show that he had recurrent episode? Okay, that's number one. Number two, what is that asthma? This is 4-year-old, isn't it? Sarah?
3 years old.
3 years old. Number 2, what are other features of asthma? So it must be recurrent. One off, you cannot say 2 weeks. No, I cannot. It's not chronic lagi lah. 2 weeks okay. Kalau 6 months ke, 1 year ke, of similar episodes, then that will be chronic lah, okay. 2 weeks, no. I mean, unless this is part of the symptoms that's known or diagnosed in the past. So he's been presenting with a cough since he was 2. She's been having coughing on and off, triggered by whatever it is, Then that will be okay. I can buy it lah, okay. Okay. Anything else? So one is those chronic, recurrent. Number 2, what are the other features?
Wheezing,
Current.
doctor?
Wheezing, anything can be wheezing, Badrul. Anything can be wheezing.
Triggering factor.
Sorry, triggering factor. So what are the triggering factors? Here is strenuous exercise. So I think that is very important, strenuous exercise. Okay, any other triggering factors?
Pets.
Okay.
Cold temperature.
No, it should be asthma. It should be multi-trigger. It's not single trigger. Betul lah. One of the thing is exercise induced is asthma lah. But then it should be multi-trigger. So which means it does not mean it's only related to infection. It can be related to dust, whatever lah. Dust, temperature, food, whatever. Okay. There should be multi-triggering episodes. Bukannya single trigger. If it's upper respiratory tract alone, it's not asthma. You must remember that it's only one trigger. It's not asthma lah, unless if it is exercise induced lah. Exercise induced, that's asthma. But the rest of them is not asthma lah. It's only upper respiratory tract, and then followed by episode like bronchiolitis. So maybe just only virus induced wheeze. It's not really a asthma. So anything else? Feature. So in the history, when you take the history, you need to tell me or tell the examiner the clinical, or not the clinical, the typical, right, isn't it? Yeah, typical features. Janganlah you tell me something. Presentation is about you regurgitating the information and telling me specific information that you took from the history or from the parents. I mean, this is, I know, it's just only imaginary kind of like history. But still, in the imaginary punya history, you still need to fulfill the criteria to state your claim or state your claim as this is asthma. If not, then there's no point of stating that claim. This is asthma, because I say it's not asthma, okay? It's only 2 weeks. You think it's really asthma? Does it have any coexisting problem rather than asthma? So those are the 2 issues. Number 3, what are other issues? What are the typical features? Typical features. Family history, apa lah? Okay lah. Anything else? Typical features, guys.
Worsening symptoms in the morning and improvement as the day progress.
Tadi kalau kita discuss kan, I said nocturnal, cough, diurnal variation. Kita dah discuss tadi, okay? Anything else?
Eczema can, doctor.
That's eczema is just only comorbid, nothing more than that, okay? Anything else? Reversibility, what does it mean, reversibility? Ada orang tahu kalau reversibility. You give, yes, Mustaqim?
When the trigger is removed, it is improved.
Not when the trigger is removed. When you give bronchodilator, it's improved lah, kan? Because it's bronchospasm. So when there is a narrowing of the airway, you give bronchodilator, it's improved. That's asthma lah. So the history to suggest of reversibility, maknanya visit to the clinic kesihatan ke, and then give a nebulizer and it's improved following that. Then that's typical lah, basically. Typical history of asthma lah. Needing nebulizer or inhaler. That's typical history of asthma. Okay? So, history, as I mentioned to you, need to be improved. This is very superficial to me lah, okay? To me. Because when you come back in your clinic stay or to the hospital, this is our bread and butter. So when it is our bread and butter, you need to tell us detailed history. Detailed history. Why do you think this is asthma? Did you not explore in terms of asthma severity? Apart from daytime symptom, nighttime symptom, activity, isn't it? Those are the things that you look for. Is there anything else? Exacerbation. Is there anything else? Exacerbation. Is there any exacerbation in the past? Hello?
It stated that he has had similar episode in the past, but this time it is the episode worse. So I think there is some exacerbation.
You need to highlight it in the history. Nobody is telepathic to know. Okay? When you are doing the history taking, or not when you're presenting the history taking, please make sure you regurgitate those information. Okay? Don't just keep it to your chest, because the examiner may not know what is in the history. If this is relevant history, to state this is asthma, to say that this is important, to highlight the diagnosis, then you should tell okay? You cannot tell it at the end. I mean, the examiner will think that do you understand of the problem or not? If you put it in the past medical history,
Accessibility factor maybe
if you put it in the past medical history, it's not going to be you're not going to be do you really understand of the problem, or you just taking the history superficially? So it is important for everybody to highlight if this is significant history. You can say of note, he had twice episode of presentation to the GP. At that time, he wasn't referred for admission, but requiring nebulizer. Then that will be much more clearer, rather than keeping it to yourself and then say it at the end of it. Okay? Understand?
Yes.
And then the other thing as well about because if this is asthma, then the needs for you to quantify what type of asthma is this. I said severity just now. What do you think of the asthma severity? If this is asthma,
Mild to moderate asthma.
what do you mean by that? Severity. There are three things here. You state, A, severity of asthma. Is it intermittent or persistent asthma? Isn't it? B, when the child came here, because you said this is not acute exacerbation. If it's acute exacerbation, you want to know whether this is mild acute exacerbation, moderate acute exacerbation, severe acute exacerbation. C, when it is started on the medication, then you are going to quantify whether this is controlled or not controlled. You understand what I'm trying to say, yeah? Complex or not complex?
Yes, okay.
Anybody else? Do you understand what I'm trying to say?
Yes, doctor.
Okay, so A, in the history, because this is the first time you are going to take the history, you want to establish what type of asthma is this. So the history, although this is the presentation, prior to this presentation, what is happening? Is it intermittent or is it persistent asthma? So the history that you should be taking will be related to, again, all these things, the need to use of inhaler, the what you call exacerbation, the cough, isn't it? Or do they have any daytime symptom, or do they have any nighttime symptoms prior to this? Because you want to say, okay, this is intermittent or this is persistent asthma. Now he presented with much more worsened problem. Okay, and then you can quantify, because if it's persistent asthma, so what's the problem? Persistent asthma, Maisara.
It occurs every day.
I know, tapi kalau persistent, what do you want to do? Every day pula dah. Okay. You are going to start on medication lah kan? Mana ni? Tak baca apa semua ni You are going to start on medication. Now, can you go down to down to page whatever you have asthma severity. Down. Back, not back, down. Again, down. Okay, that one, okay. Okay. So what does it mean by this? So when you ask the history, okay, this is what I mean. You want to quantify whether the child has got intermittent or persistent asthma. Because at the end of your history nanti, you are going to make a remark or summarize the problems. This is a child, based on my evaluation, he's got mild persistent ataupun moderate persistent, whatever lah. Because it's probably, I don't know, prior to the presentation, was it been diagnosed as intermittent or persistent asthma? I don't know. So you've got to take all the history in order to qualify and state your claim that this is asthma with what? Background of persistent asthma, mild persistent asthma. Because if it's mild persistent asthma, therefore, the reason for it is that if it's persistent, then you can start on, the management will be starting on steroid lah, therapy, prophylaxis. If it's intermittent, therefore you don't need steroid. Maybe it's just because of exacerbation. You understand what I'm trying to say? I don't know whether you guys catch it or not.
Yes, Doctor.
Yeah, so history must be tailored to this. Jangan just reading everything without understanding. Okay, down. What is this? This is acute exacerbation. Severity in acute exacerbation. So because you said just now, the patient present to you with coughing in a what you call outpatient. Maybe not. Maybe there is an element of acute exacerbation. Maybe no element of acute exacerbation. So if there is any element of acute exacerbation, which means the child is in respiratory distress. So that's why I said to you, you need to know the respiratory distress. So then acute exacerbation, there's a different pathway altogether. Because this is a child who presented to you in respiratory distress because of acute exacerbation. Prior to that, you need to tell what sort of asthma is this. Okay, down. Now, this is what? Just now. Okay, what is this? What do you understand of this? Asthma control. Mai Sarah?
Sorry, this one, Kosla will explain.
Kosla, okay. What do you understand about this, Kosla?
Yes, doctor. This is for once the steps or treatment has been initiated.
Yes, okay. So when the treatment is initiated, then you have to assess whether it is controlled or not controlled. So this is more related to treatment. So the first one just now, we're talking about prior to, you want to establish whether the patient needs treatment or not. The second one is when there is an acute admission. The third one, this one, is more related when you start the patient on treatment, which is maybe prophylaxis or combined therapy. Then you want to assess all these things to state your claim again, whether this child has got control symptom or not. Well, at the end of at the end of your presentation, you want to say, okay, this is a child, 4-year-old child who presented with, say, for example, mild acute exacerbation of asthma, currently on nebulizer. This is on the background history that he had symptoms to suggest of mild persistent acute asthma, which are triggered this time due to exercise and I don't know whatever exercise. Unfortunately, he was started on prophylaxis, but he's got some symptoms to suggest of partially controlled asthma from the history. Now, then I will see the full picture of what you're trying to say to me on the asthma history. You get what I mean? Hello? I don't know. Am I talking?
Yes,
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 doctor.
okay.
Yeah. Make sure when you're talking all this, I mean, you're putting all the information, but I want you to understand, not just putting all the information per se, to understanding, because this is your bread and butter. If you get asthma in the long case, if you cannot perform and cannot say or understand what you're trying to do, therefore you're going to fail definitely, because it's our bread and butter, and it's you know, it needs to be in. You need to understand the full picture of it. If you just understand partial picture or superficial presentation, definitely you're gonna fail. Definitely. Okay? For definite, because it's our bread and butter. Because nowadays asthma is being managed efficiently. Nobody dies because of asthma. And if you're not able to reiterate or reevaluate or understand the full concept of it, therefore it is not good lah. You're not showing. So I think don't take it heavily, my Sarah. Because I'm very, what do you call, strict in the presentation. So I expect everybody to understand asthma inside out. So the history that you are taking must reflect whatever the underlying problem is. Okay, you cannot just say just like that and then this is asthma. 2 weeks is not enough. You need to suggest to me more that this is a chronic sign. You need to suggest more on the history prior to this presentation, what is happening. You need to suggest to me if it's been treated or not, or if there's any severe exacerbation in the past, and if this is exacerbation, what type of exacerbation. Okay. All right. Okay, Maishara, you can take over again.
Okay, doctor, thank you. Back until the birth history. Okay. Okay, for the birth history, he was delivered at term with spontaneous vaginal delivery, and for the antepartum, intrapartum, and postpartum, there was an eventful history, and the birth weight was 3.1 kilogram. For the feeding history, he was exclusively breastfeeding for 1 year and 6 months, and formula milk, followed by formula milk and weaning was introduced after. Currently, the balanced diet and formula milk. For his developmental milestone, it is up to age, and he went to preschool, and the performance is good. He is able to run, able to speak and communicate, and also was trained to go to the toilet. For the immunization status, it was completed up to age. Systemic review, so there is presence of eczema on the skin, and otherwise the bowel movement is normal and normal maturation, and also no joint and muscle pain. Okay, next. For the past medical history, he has eczema and dry skin since infancy. He has no allergies and no surgeries, and also no history of accidents or significant faults. For the drug history, he was given antihistamine syrup and salbutamol inhaler when the coughing first occurred, and then initially the cough improved but worsened after the next 2 days. Okay, for the social history, he goes to preschool. He plays soccer with his friend and has minimal coughing.
Okay, drug history. Can I just the drug history too? You said already. When was he started on this drug salbutamol inhaler?
Actually, the salbutamol inhaler is from his brother, because his brother was also an asthmatic patient.
Okay, how did it? How was it? Was it administered? You didn't tell me how. How was it administered? Salbutamol.
Uh,
Is it directly?
after the when he is coughing, the mother will give
Yeah,
the
how
salutary.
was it directly, or was it using air chamber or spacer, or what? How?
It using the M
MDI is meter dose inhaler. Inhaler lah, MDI.
yeah.
So how was it given? Because if it's given wrongly, and therefore the technique is wrong, and this is also vital information that you need to highlight in the history itself. Okay? Takkanlah you nak highlight sini, okay? So you need to highlight in the history. If it's it's been started on saya bertemu by parents, unfortunately it was not given using the aero chamber. Okay? I mean, or if it's using aero chamber, who check the techniques? Does the mother knows the correct technique of giving aero chamber or not? Because you want to highlight, if this is asthma, you want to highlight this is a part of the problems in the management of asthma. Okay? What about the social history? What are other important social history? Apart from preschool, blah, 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 and everything. What are social history? I want to know more. Is father a smoker or not? That's my social history that I want to know.
Just no smoker. And
Okay, right. What about environment? Does he live in an area where there's smoke, or I don't know, something, quarry or whatever?
no.
You need to regurgitate that information. I cannot read your mind. Okay, please. When you are doing the presentation, you regurgitate the information. You can't really keep it abreast in your heart. I don't know. Okay, please regurgitate the information. I cannot emphasize more. You cannot. If I ask you a question, which means it's inadequate. If the examiner asks you a question, what are the history? So which means you're not presenting adequately. Okay, so please voluntarily regurgitate that information. I mean, the important, what I'm telling you here is important information. You need to tell about whether there is any trigger in the environment, especially smoke, especially environment. Maybe you want to tell about carpets and pets, that's fine. But if you don't tell, nobody will going to know. Can we read? I don't know. I can't read your mind. Is it enough? I don't think it's enough. I will tell you it's not enough. Unless you tell me it's enough. So I think it is important for you to be more, I would say, complete now, okay? In the history, please. All right, okay?
Alright. Okay, thank you, doctor. Okay, next for the family history, he has two siblings. And their brother and grandmother has asthma, and the sister has eczema, and the grandfather died of heart attack. Okay, next we got next is physical examination. Okay, for the general examination, the mental status and general condition of the of the patient is he is alert and cooperative, but in minimal distress. But she showing no pain and the skin color is normal. And for the vital signs, the temperature is 38.1 degrees Celsius. The pulse rate is 100 BPM. The respiratory rate is 24 rate per minute. The blood pressure is 85/65 millimeter mercury, and the oxygen saturation is 99% in the room air. Okay, for the temperature, it is actually a mild fever. For the pulse rate is normal, and the respiratory rate is within the normal range, and the BP is normal but slightly decreased. For
Make
the
sure, what do you mean slightly decrease? I don't understand.
uh, because
How do you know it's normal BP?
it is within the normal range.
What do you mean normal range? What is normal range for 4-year-old?
Within
Hmm?
88.
Huh?
88.
How do you know this 88 is normal? What is what is normal for a 4-year-old versus 5-year-old versus 6-year-old? So it must be it must be following
Chart, anthropometric chart.
anthropometry centile chart lah. Okay, BP centile chart.
Centile chart.
So how do you know BP centile chart then? You look at the
Must know height,
Ah.
height of the patient,
Yes.
gender,
yes, and
Age of the patient.
okay, age, gender, and height of the patient. Then you will be able to tell me what is the centile normality lah. Okay, if it's 50th centile, then it's normal lah. If it's 99 centile, then it's abnormal, isn't it? I don't know. You need to be objective lah in term of giving those information. Betul lah, heart rate is normal, respiratory rate is normal. But then if you want to say BP 85, is it normal? You need to give me range or centile. What is the centile for that? If you don't give me the range, centile range, then therefore we don't know. Is it 4-year-old? Is it normal? I don't know. Okay, you need to do it. Okay. Similarly to all these anthropometry. Okay, what is the centile? Make sure you tell us the centile. Okay, jangan 97, 40 kilo. What is it? I don't know what is this. Okay, just plot it on the centile chart. You're coming to pediatric here, and this is essential because why is it essential? Alia Riley.
Yes, doctor.
Why is it essential to plot the anthropometric?
So that we can know the development of the patient.
No, not really. Not development, come on. Amira?
It's just that you know
yes.
whether the patient is in the normal percentile or not in terms of the.
It's not about normal percentile. It's just only to tell us or to illustrate to us that this child has got a chronic problem or not. So if a child is on the 3rd centile or below, therefore the child is not growing, isn't it? If the child is height-wise is less than 3rd centile, the child is not tall, short. So why is it short? Why is it failure to thrive? Weight is low. So it must be a chronic sign. So if the child has got chronic sign, for example, like asthma, which was not controlled, therefore we can say that this is poorly controlled asthma. You get what I mean? Yeah. So all of these are information which is important, vital for your processing all the information to state to you, to state later on when you want to state, okay, is the child is in distress or not? Does the child have got some chronic problems or not? Does the child have got any other comorbidities or not? Okay. All right, Maisara, go on.
Okay, next, the systemic examination. There's no finger clubbing, no peripheral cyanosis. The skin is dry but not flaky, inflamed or thickened. There is presence of multiple small lymph nodes in the upper neck, which indicate lymphadenopathy. No dilated vein, and the eyes are clear, which means there is no sign of conjunctivitis, and there is presence of clear discharge at the nasal mucosa, and there is presence of tonsillar hypertrophy. Okay, next. Okay,
what else? Sorry, stop there. What else in the nose that you have to look for? Since you mentioned that the child is in the history, the child was sneezing a lot. Does the child have comorbidity? What are the comorbidity related to asthma?
Eczema.
Come on, in the nose.
Productive cough.
No lah. Allergic rhinitis, okay? Okay. Later on, Amiro, since you answer. Nazla, since you answer this. Look at the allergy allergy march, MARCH. What? In the Google, you Google, find prevalent of allergy march. Okay, and then you tell us later. Okay, continue.
Okay, next. Okay, for the specific examination, there is increase of antero-posterior diameter of the chest, which is indicate hyperinflated chest or parachest. The chest moves symmetrically with respiration, and there's no scars and no dilated veins. For palpation,
What are other clinical signs of chronicity in asthma, apart from hyperinflated chest?
chest recession and
That is
retraction.
for acute problem. Because this child is not acute, it's not the kidney, so you can't have any chest recession, isn't it? Chronic. If they have been coughing for a long period of time, so what are the clinical signs you expect to find?
Doctor, what about Harrison sulcus?
Thank you very much, Alia. Okay, Harrison sulcus. So, does he have any Harrison sulcus? That's much more important for me rather than barrel chest. Yeah, this is hyperinflated chest wall, pigeon shape, But then like that, I mean, a child who's had asthma, they will be coughing and spluttering for a long period of time. Therefore, they should have a clinical signs. And those clinical signs, which is much more important, is Harrison sulcus. Why Harrison sulcus? Tina dialect? Tina. Right, am I speaking right? Tina? Okay. Okay. I cannot get anybody. Alia, you want to answer? Why Harrison sulcus?
I just know that it shows that it is chronic, but I'm not sure about how does it happen.
Okay, you read and tell us, okay? Although I can explain, but I don't want to. I want everybody to read, okay? Alia will read and tell us at the end of it. Because Harrison sulcus. Why is it important to recognize the Harrison sulcus? What is the physiology? The physiology? How did it develop? Okay, something like that. Okay, come on. Let's move on.
Okay. Not yet. Back. Okay, for the palpation, there is the trachea is centrally located. For the chest, as mentioned, it is symmetrical on both sides. For vocal parameters, bilateral symmetrical vibrations, and the apex beats palpable at for the fourth intercostal space. And for the percussion, there is hyperresonant to percussion due to the hyperinflated chest. And for the auscultation, there is vesicular breathing with prolonged expiratory phase. There is presence of bronchi during expiration, and there is occasional wheezing, but there is no retraction. Okay. Next. For the diagnosis, we come up with bronchial asthma due to presence of nocturnal cough and early morning exacerbation. Recurrent wheezing with triggers such as playing, exercise, and cold temperature. There is history of eczema and family history of asthma. The barrel-shaped chest, and vesicular breathing with prolonged expiratory phase and expiratory bronchi on auscultation. And okay, for the differential diagnosis, we listed out the three, which is bronchiolitis. First is bronchiolitis.
I don't expect bronchiolitis, sorry, because why is it not bronchiolitis?
Because there's no coryza symptoms.
No, it's not. It's age less than 2. Number 2 is at first episodes. It's not recurrent episodes, okay? So it's not typical nocturnal cough and everything, okay? So If it's first episodes of similar kind of like, first episode, less than 2-year-old, then I would expect bronchiolitis is one of the differentials. But if it's 4-year-old, don't label anybody with bronchiolitis because it's not. Okay, it's not going to happen in 4-year-old. So that's it then. Okay, all right.
Okay. Next is transient early wheezing. We put it here because for children younger than 3 years old, it is actually common. And also there is wheezy bronchiolitis. But for the relevant negative, there is no history of maternal smoking during and after pregnancy, no history of premature delivery, and it is not virus associated with an episodic viral wheezing. Okay, and also for the third is the pneumonia. It is because of the low grade fever and the cough and runny nose. But the relevant negative there is no pleuritic chest pain, no neck stiffness, and no abdominal pain. Okay, next. Okay, for the investigation, there are 3 investigations that was carried out. First is the skin prick test to denote any allergic reaction. So there is positive aeroallergen skin prick test. And next is exhale nitrate oxide testing.
Just can I just exhale? I mean, these are all research. Chest X-ray is not done basically. Okay, it's done in acute, but well, you can do it. But I mean, if it's recurrent, it's no point. If it's typical, skin prick, make sure that you know what is the aero allergen. But asthma is more than that. Asthma is not purely allergic. Asthma can also be non-allergic component. For example, like exercise induced. You don't have aero allergen for that. Or laughter, because you laugh and then too much laugh and then you get asthma for that exacerbation. Or obesity, isn't it? Pregnancy asthma. It's not related to aero allergen. So it's a heterogeneous kind of like disease, and some may be related to aero allergen, some may not be related to allergen. So this is not fundamentally tested for asthma. Although, if you know that the patient has got multiple trigger, which is known to you, that it can trigger. I mean, certain food may not have allergen that you can test on. You can test if the patient has got allergic tendency to house dust mite, to grass pollen, to cockroaches. Yeah, you can do it. But if you are allergic to strawberry, nobody has allergic to strawberry or mangoes. Nobody has it. So be careful on. I mean, like if you're going to do skin prick test, it's for the typical those who are what you call allergic to known allergen rather than unknown allergen. You can do on unknown allergen, but then there are so many allergens in the world, and some of them we may not be able to produce anything. So just beware on all this investigation. Lung function test, well, it's not been done because it's 4-year-old, isn't it? So 4-year-old, you're not going to be able to do. I mean, like if it's more than 6, 7-year-old, then you can perform it for peak flow, similar to peak flow as well. But that's not really. So all the cases must be based on the history of physical examination per se, in the age of less than 5 years of age. Then we come into all this. Who's supposed to be talking to me just now? Amiro, is it? Amiro? Okay, tell me about allergic march. Tell us, educate us on allergic march. Mm, mm. So the value, the value of this, what is the value of this information? The value is that everybody, like food allergy, you're going to diagnose it less than 1 year old. Eczema, the prevalent, so which means you're going to diagnose everybody mostly around 1 year old. Asthma, you're going to diagnose everybody more than 5 year old, isn't it? More around 5-6 year old rather than 3-4 year old. So which means that goes back to the diagnostic criteria. These are all predictive index. What you say, predictive index does not mean because asthma, as I mentioned to you, is a heterogeneous condition. Some may have positive skin, some may have eosinophilia, some may be positive aeroallergen, but asthma is more than that. So it's more than like I illustrated just now. It can be obesity related. It can be perfume related. You just spray the perfume around or spray the perfume, and then somebody have a tendency that then it's not. You don't know what chemical inside the perfume. It can also be some other condition that might be of note. So then it's not purely histamine related, Although we're talking about allergic tendency, there are sections of asthma which is not really allergic, have allergic component. Okay, so be careful of what you are interpreting. And one is when is the most common. Second is the criteria for the diagnosis of it. Okay, especially in less than 5 year old, because you cannot perform any of those like nitric oxide or what, chest X-ray boleh lah. Lung function no way. To diagnose asthma, how do you do it? To diagnose asthma, Maisara?
From the history taking and also physical examination, and also for the lung function test, the spirometry is a good examination to confirm asthma.
So which means you have to do spirometry or peak flow in order to obtain and consensusly agree that this is asthma. But in the less than 5 year old, can you perform that?
No.
Yeah. So we're not going to be able to. Not that I'm not saying that we're not going to be able. We are just going to be based on the history of physical examination. And the physical examination, one of the physical examination that we are looking at, apart from hyperinflated lung, is Alia. Oh, Alia.
Yes. Yeah.
Yeah. I asked you to look at the clinical
About the
side.
Harrison.
Why is it Harrison Sulfur?
So yeah, Harrison sulcus is basically an indentation on the chest, roughly at the 6th rib, and usually it is bilateral and sometimes it occurs unilaterally. And about the Harrison sulcus, it's basically it usually occurs in chronic obstructive airways disease such as asthma, and because of the muscular insertion. Because there is muscular insertion of the diaphragm when the patient during respiration, and that is why.
So why is it diaphragm?
Why what?
Why diaphragm? Why not intercostal muscle? Because
I can answer that one.
Badrul, can you help Alia?
For the lung capacity?
No lah, because the biggest muscle in children is diaphragm, kan? The biggest muscle for respiratory for us is intercostal. But the biggest muscle, that's why when you see children, you will see the seesaw pattern of breathing. When you want to calculate respiratory rate, you look at the tummy, because they use the diaphragm in order to increase the airway, expansion, chest expansion. So it's diaphragm instead of using the intercostal muscle. So similarly as well, when you're coughing, you're going to use diaphragm. And that's where you get invitation, because you've been coughing for chronic long period of time. And that's why you see Harrison sulcus. So understanding of all this clinical context will give you the clue to what is the underlying problem. Although, Alia, what is the differential for Harrison sulcus? Can it be anything else?
Wait, let me check.
Ya ni tak baca habis. Okay, all right. It can let me tell you lah. Okay. So the differential will be if you get what you call rickets lah. If you have rickets, you can also get similar features like that. But then rickets, you need to see other features related to the swelling of the wrist joints and also X-ray changes. Okay, come on, let's go. I think I'm taking too much.
Doctor, one question.
Yes.
About rickets, what I've read is about it is related to the bone weakness. Is it true?
Yes. Okay. Rickets is dietary. Most likely is dietary. Okay, rather than anything else, or less exposure in a country, for example, like Saudi Arabia. It's very intriguing to see ricket is so much there because of they wear black cover. And they tend to be in the what you call in a house rather than outside, playing outside. So hence you get less vitamin D, and then you are predisposed to ricket, especially for children. But in our setting, perhaps it's more nutritional related. So rickets can be either vitamin D related, for whatever vitamin D problems. B, nutritional problems. C, maybe related to gut, because when you are having problems absorbing vitamin D, and then you are predisposed to ricket. D, may be related to the renal issue. So if renal cannot convert whatever the nutrition inside and then convert into vitamin D, also you can predispose to ricket as well. So you need to understand the pathophysiology behind it in order to locate what is the current problems related to that. I mean, just this is side issue, okay? So asthma is most important. Okay, come on, next. Tired now. Okay, I think we skip this one now, okay? Why are you giving nebulizer? Wait. Why are you giving nebulizer?
This one is the case management. This is how
I
they
know.
manage.
Why nebulizer? I just want to know why.
I think it's because they want to relieve the patient's.
But the patient is not.
First.
You said in the history there was no tachypnea. Is it correct?
Yeah, there's no tachypnea.
No tachypnea, no nebulizer. Okay. If you want to give inhaler, I would agree on you. But if it's not tachypnic, if it's tachypnic, then I would agree you can use nebulizer. Okay. But if it's not tachypnic, it's just only coughing. So yeah, the airway is swelling, and there's some element of bronchoconstriction. So steroid, I think, is acceptable. Paracetamol, okay, maybe because of fever. Inhaler, yeah, I think that's acceptable. And nebulizer, maybe not, because you told me in the vital signs earlier on, there was no tachypnea. It's only 24. So there's no point of doing so. And then initiate long-term plan. What is the long-term plan?
The long-term plan for this patient, because we think that the patient might be suffering from moderate persistent asthma.
Okay.
So they should be given moderate doses of inhaled corticosteroids.
So you start with the steroid lah, basically, okay?
Yes.
So things that which is important here when you are talking about long-term asthma, A, you start on prophylaxis. B, the techniques of giving the steroid itself. So you need to give, I mean, in 4-year-old who might not be able to coordinate using the inhaler directly into the lung, instead of giving the inhaler direct to the oral, perioral area, going to the lung is maybe impossible. Squeezing the inhaler and then try to inhale together, so it might be impossible. So you need to use the spacer or aero chamber for that. Number 2 is the compliance. When you start on it, there's a need for you to emphasize on the compliance of the medication. And number 3 is avoiding whatever the trigger. So the history must also relate to the trigger. What are the trigger? Common trigger. So if it's exercise, therefore the child should have inhaler prior to doing vigorous activities. Number 5 is that if there is any comorbidity, you illustrate earlier on. It's about comorbidity. I mean, he was sneezing early morning. So what does it indicate? Indicate, Maisara or Kosla?
Allergic rhinitis.
Yes, allergic rhinitis. So what? So how do you confirm allergic rhinitis, Adlina?
Family history.
Anything else? Okay, history. Lagi, physical examination. What physical examination do you expect? Fine.
Pain in the eye and
Allergic rhinitis. It's rhinitis because of allergen. You know, whatever it is in the environment, especially house dust mite. So therefore, they are presenting with a runny nose, sneezing, itchy eyes. So you will see shyness. But itchy eye, they will what you call rub their eye, and then they will get black shyness. Okay, they will have runny nose and they will do allergic salute. Yeah, salute. So you have a crease over here. Okay, nasal salute. And then the third one is that you look into the nose, looking for nasal terminates, what you call hypertrophy of the inferior nasal terminates. And that's confirmatory that there's an element of allergic rhinitis. So you should manage allergic rhinitis using steroids for the nose as well. So those are the things that you should be aware of. Notwithstanding whatever we mentioned about the initiate long-term treatment. I'm just saying you don't need to know in detail, but compliance is very vital. Technique is vital. If there's any comorbidity, you treat it. And also, if there's a potential trigger known to you, you treat it as well. Especially smokers. Okay? All right. I'm so tired now. Can we break for 2 minutes? I want to get some water and then that's it then, okay? We can start again. Okay, sorry. I'm also tired now. Okay, let's go. I think that we are not going to discuss this, okay? Step, okay, you can read it over, okay? We go to the second one.
Okay, good afternoon. Can you hear me? How is everyone?
Okay, Ravan.
Okay, we're gonna proceed with the croup laryngotracheobronchitis. Next slide. So our patient is Denisha, is 3 years old, female, Malay, from Banjaya, Kelantan. The affirmative will be mother. So next slide. For case timeline, so our patient coming of a problem before 4 days. On Sunday, she presents with a cough began, clear nasal drainage and nasal congestion. For a Monday, cough start worsening and a clear nasal drainage and nasal congestion. For Tuesday, same symptoms of Monday, but the fever start, and at evening the temperature is increased at 40 Celsius, and later it's become down between 38.3 to 39.4 Celsius between doses of paracetamol. So on a Wednesday, the upper lip is mildly swollen, and she's refused her mother to wipe her nose and come to outpatient clinic with the admitted. Next slide. So for history taking, the chief complaint was harsh cough, nasal congestion for 3 days, barrier to admission to hospital. On a 1-day barrier to admission, she developed high-grade fever to moderate. On the day of admission, she complained of a swollen lip as well. So our presenting complaint was the major one is cough for 4-day history of non-productive cough, and with onset of fever on day 2 of symptoms. The cough has perky quality and worse within the patient's lay down. No hemoptysis. For a nasal congestion, she had a clear nasal drainage for several days and significant nasal congestion. She refused allow her mother to wipe her nose in last day of admission. For a fever, on a Tuesday evening, she is increased to 40 Celsius and become down between 38 to 39.4 Celsius between paracetamol. Sudden onset of fever, no chill, no rigor, no tepid sponging was provided by mother. For lip edema, her upper lip is mildly swollen and she has decreased appetite and taken her less fluid by mouth. Next slide. So for a systemic review, for general health, she seemed lethargy, ill-luck child, and the current fever, cough, congestion, and lipedema. For skin, nails, and hair, no excessive sweating, no rash, no dryness, no hair loss, no nail changing. For hands, headache, no visual disruption, head and nasal congestion for approximately 4 to 5 days. No nasal congestion at present. Sty, which is as we can see in a picture in a right lower lid since November. She was consulted for this. An antibiotic drop was prescribed, completed. Breast defrate, and for chest and lungs, sometimes she have difficulty in breathing at rest, and current with the croup cough, but no history of reactive airway disease. For cardiovascular, no murmur, no edema of lower extremities. For peripheral vascular, no changes in color extremities. For GI, peptide fair, no gastroesophageal reflex, no food allergic, no constipation or diarrhea. For GU, potty trained, occasionally nighttime accident happen. Endocrine, no temperature intolerance. Musculoskeletal, no muscle wasting or pain, no difficulty with walk. For neurology, no dizziness, fainting, or seizure activity. Psychiatric, no anxiety, no behavior concern. So next slide. For past medical history, illness was she has sty in November, her so allergy, no allergy from penicillin, and surgery, no. For drug history medication, she was giving between the fever paracetamol 120 milligram per 5 milliliter in oral suspension for hour per day. For pediatric history, for antenatal and eventual pregnancy, took supplement by a doctor as a folic acid, vitamins. Intrapretum, 36-week infant was born by gravida 1 para 0. She weighed 2.72 kilogram at birth, normal. Postpartum, no complication. For feeding history, she was breastfeeding, but mother cannot recall when she's exactly stopped breastfeeding. Semi-solid fluid was given around 6 months. No normal and balanced diet. For immunization is up to her date, and she's following in good health. Next slide. For development history, she has a no development delays. So gross motor was ride a tricycle and kicking ball forcibly, walk in tiptoe and standing in one foot. Able to grow, goes up and down on a stair alone, 2 feet per step. For fine motor, able to make tour of 9 to 10 cubes. Draw man on request and cut with a scissor. In speech and language, give a full sentence, gender, sometimes age. Ask many questions, where, what, who, identify object by function. For a social, eat independently, wash hand, joins in active makes believe play with other children, understanding sharing toy. For a family history, no congenitally marriage. The child family history is negative. For deafness, no nasal allergic, asthma, tuberculosis, heart disease, hypertension, hypercholesteremia, liver disease, kidney disease, diabetic, alcohol and drug abuse, mental illness, mental retardation, malignancy, and immune disease or conditions. So, next slide. For a social and environment history, she's living at home with her mother, father, and 17 months old brother in a Banjaya Kelantan. Her mother is requested as a nurse and work in mammography in HRBZ. Her father was a policeman at IBD Cotabajo. The patient was living single family home and adequate resource of food and clothing. Healthcare insurance adequate and provided through her mother, employer. The children extended family is close and spend time together in a weekend and holidays. No one smokes in the family. Next slide. So we move to physical examination. For a
Okay, Rawan, stop, Rawan. Okay, can we? Before we go to all this physical examination, in the history, can we go back to the history? Okay. Oh, yeah. Okay. So if I ask you, what's the main reason for this? This child is being admitted to the hospital, isn't it?
Yeah.
Okay. So, sorry.
Berkey cough because she's having cough before 4 days.
Okay. So if I were to ask you, what is the reason for admission or the reason for you to admit this patient? What is the reason? Right? What is the most important thing that in light of the presentation, everything, cough, nasal congestion, fever, which one is the most problematic, concerning that would you that has led you to admit this patient or not admit this patient?
Okay, I think it's fever because we can suspect some viral or bacterial infection because
If you say this is fever, so admission for fever, well, I mean, like depending on what you say, because I mean, like if it's fever because of COVID-19, then I don't know. Maybe you want to admit, maybe you don't want to admit, isn't it? Maybe you want to admit because you want to see progression. If it's fever because of viral illness, yeah, if you're swamping the ward with all viral illnesses patient, there'll be like like a room with so many. So I mean, the thing is, what I want to emphasize here. What do you think was the reason for mom presentation or bringing the child over for admission? That's the reason. Is it cough? Well, if it's cough, then does it require admission for cough? Or is it?
maybe prolonged cough and then other symptoms start appear like fever and lipedema. So the mother start concerned more what's going on.
Okay. So whatever the history of presenting complaint must tailor. I mean, like I don't know. I mean, like because this is not. You also took the history from somebody, isn't it? So whatever the history, I mean, like if you're going to admit a patient, um, does that mean for the first? I mean, like would you differentiate? I mean, this child who needs admission or not admission? You get what I mean? Yeah. So if the patient presents with a harsh cough and nasal congestion, how do you decide this one needs admission or what? I mean, or is it because of harsh cough, nasal congestion, and fever? If there's a fever, I will admit. If there's no fever, so there's a reason for admission for all those things. Whether I mean, like because in parallel to whatever the topic for today is respiratory distress.
Mm-hmm.
So the highlight should be
Respiratory distress.
okay. So the reason for you to admit because maybe it started with a heart cough, but then like the child has had respiratory problems or not sleeping and etc. Whatever lah, okay, whatever lah. But the point that I want to make here is that how you highlight the information that you have from the parents will tell you any single information. I mean, will give you all the information, but you are the one who are going to divide, rearrange, reorganize, and to say when you are examining or when you presenting to the examiner, you're going to highlight because of the topic for today is respiratory distress. So you want to highlight what is the most important. I'm admitting this child. Perhaps it's respiratory problems rather than highlighting the side issue related to not respiratory problem. You know what I mean? If you're highlighting, so why? That's why I'm asking you. Is it a child who needs admission to the ward or not needing to the ward? If it's needing to the ward, why is it? Like the first one earlier on, my Sarah said that the child presented to outpatient with a cough. So that's understandable. So we're not going to admit the child, but then we're going to diagnose the child with a cough. So what's the underlying problem? So the trouble for you is that it's how you tailor that information to highlight the most important point in terms of what is the respiratory problems here, okay? So similarly, in this case as well, I think the most important thing is for you to highlight what is the problem here, isn't it? Although you say fever, nasal congestion, cough, and etc. But why? Why is it important at this point of time? He's had it for 3 days. Why is it not day 1? Why is it not day 2? Why is it now? So that's where you should be, thinking. I mean, like if this is mom brought because of progressing worsening of the cough affecting the breathing, so that's the most important thing, isn't it? In order for you to highlight what is, crucial things to the examiner, that this is the most important thing. Okay. So as I said to you, I mean, like you are the one who will have to highlight what is the pertinent points in the history. rather than putting everything all together. So you need to jigsaw puzzle the most important point to highlight, okay, this child, well, if it's respiratory, then yeah, you need admission lah, isn't it? Rather than if it's not, if it's just a fever, well, investigation of fever. Yeah, but it's not very long. It's only 3 days. If it's viremia, you just treat with supportive treatment. You don't need anything else. But why? Why admitting? I mean, does he have any other things? I didn't explore your history of the physical examination yet. But still, in the history, you need to highlight what is important in the in your presentation. Okay. So that's my comment on the history. I mean, the rest of them, well, this is an acute problem. So you got to highlight. I mean, like what is the reason for admission at this point of time? Is it just only temperature? So if it's just only temperature, then it's not respiratory, or is it temperature because of respiratory? So, but which one is the most important thing? Is it temperature per se, or is it respiratory that lead to the admission? You get what I mean? Yeah.
Yeah.
Okay. All right. Go ahead.
Okay, for physical examination, mental state, and general conditions. So, general, the patient seem consciousness, croup rate, lethargy, unlocking will develop. And for hydration, nutrition is adequate. Attachment, no any attachment like urine drainage attachment, deformity and abnormalities, no deformities and abnormalities. Respiratory distress is showing moderate sign of respiratory distress with a mild to moderate rib retraction. And for skin, it's warm and pink, dry, no rash noted, no erythematous palm, no involuntary movement or obvious muscle wasting.
Go ahead.
Okay.
Yeah, go ahead.
There was also breaking cough and hoarseness voice. For fatal signs, the temperature is 38.28 Celsius. So, for basic classification, consider low to mild grade fever. The pulse normal range is 90 to 140. So, it's a normal 131. For respiratory rate, it's 32. It's tachypnea because the normal range is 30. For blood pressure, it's normal. For anthropometric.
So one more that I would like you to do.
Mm-hmm.
You're dealing with respiratory. What are the most important things that you have to put on?
For which one?
Respiratory, isn't it? We're talking about respiratory. The child has got respiratory distress. The child has got temperature, and also tachypneic. So what is the most important thing that I want to know in terms of respiratory?
Oxygen saturation.
Yeah, saturation. Now we're dealing with respiratory here, isn't it? We're not dealing with jaundice or anemia or something like that. We're dealing with respiratory problems. So you got tachypnea. How come pulse is one? It must be tachyp. You know, if you have tachypneic, you should be tachycardic lah. Okay, you shouldn't be normal. It should be tachycardic a little bit. You know, and you need to know the SpO2 because it's respiratory. If it's not respiratory, then there's no point, isn't it? So we're talking about respiratory here. So SpO2 is needed. Why do you think it's needed, Rowan? If it's low, how low is low? What SpO2 we should expect in this child?
I'm not sure.
More than 95%, nah, kan? So it should be more than 95%, high 90s. Whatever the respiratory SpO2 in a child who's normal, without any congenital heart trouble, or without cyanotic heart issue, so you should expect it's more than 95%. So if it's less than 95%, what does it indicate? child tachypneic less than 95%, what do you need to do?
Investigation to.
Yes, oxygen lah kan. So you will give oxygen lah. That's important because you need to know that, okay? So in a child who's tachypneic, SpO2 is less than what you expected in a normal child without any congenital heart problems, and therefore it is vital to support the child with oxygen. Whatever means, you want to give high flow, or you want to give venturi mask, whatever you want to give, I mean, you need to support the child because the child has got compromised airway already, okay? All right, okay? Okay, can we move on?
Okay, for...
Oh yeah, sorry, one more, I forgot before just now, when you talked to me about all this, a child who's presented with runny nose, noisy breathing, and etc. I think it's important to highlight relevant negative to it as well. Although you put it in the you put it at the systemic review, but a child who's got noisy breathing, how would you differentiate? How would you I don't know. How would you differentiate what type of noisy breathing? You understand what I'm trying to say? Well, I mean, how many types of noisy breathing do you know?
4.
Okay, tell me, or tell us, what is it?
The normal one or
Abnormal.
Wheezing.
Okay, wheezing again. Okay, grunting. Anything else? Stridor. Okay, anything else? Stator, okay? Stator. So the location of the noisy breathing. Yeah, before. The first case, we are dealing with lower respiratory tract problems. Now we're dealing with upper respiratory tract problems, isn't it? So if it's stator, where is it the problem? Nasal lah, okay, stator. Okay, and the next one would be stridor, where is it the problem?
Upper airway.
Upper, where is that exactly? Raman, what do you think is the problem?
Laryngeal and trachea.
Yeah, trachea. Well, I mean, like epiglottitis, isn't it? Yeah, laryngeal, tracheobronchitis. Yeah, you can. Okay. Pharyngitis, so the upper airway issue. So that's why they got stridor. Stridor must be what type? Which one? Stridor must be?
What do you mean by what type?
Inspiratory or expiratory or both?
Respiratory.
Inspiratory in nature. So inspiratory in nature is stridor lah, isn't it? Inspiratory. But if it's biphasic, maybe noses, But if the stridor is inspiratory and expiratory, can it be anywhere else? It can be in the trachea. So if it's below epiglottis or below than that, if you have tracheomalacia, weakness of the trachea itself, therefore you can get biphasic stridor. So stridor commonly is inspiratory in nature. So those are the descriptors. So when you know the differences of the stridor itself, what you need to think about is the differentials. What are the differentials of the stridor? Causes of stridor, because in the history is that a barking cough. I know it's a typical history, but you are still wanting to explore the differentials as well. What are the stridor? Can it be anything else related to the stridor? So if the history may explore, I think if you think of this is serious LTB versus epiglottitis. So you need to tell us relevant negative lah. For example, is a child tripoding position, the child has high grade fever, the child is drooling or not, no evidence of drooling. So then in the history itself, you can exclude straight away the other part of the differential issue, okay? Rather than you leave it at the end of it, okay? All right, okay. We can go next.
For examination for face, neck, and head and lumps, for hand, skin and hair and nails. The skin is warm, pink, and dry. No rash, no erythematous palms, no normal capillary relief, no clumping, no peripheral cyanosis, no muscle wasting present. Nasal discharge and her upper lip mild swelling. No jaundice. She has a single 2 to 3 sty on the right middle eyelid with no discharge or edema. Oral hygiene with her with a clean soil, happy, and white teeth with no oral emission method, no central cyanosis, no facial discoloration, no puffiness, lymph neck supply with no notch or rigidity, short lymph node was present, and cervical pulse rhythm with a good volume. Extremities warm and well perfused, no cyanosis, no edema, pitting edema. For next slide. For a lung, respiratory heart steroid present with the rib retraction, Barkey calf noted, and for cardiovascular heart rate rapid with no murmur and S1 S2 audible. Abdominal soft, no tender, no distant, no abdominal active bowel, no sound, no hepatosplenomegaly, no masses. For breast, genitalia, and rectal is differed. For musculoskeletal system is no hypotonia. Neurological cranial nerve 2 to 12 intact and moves all extremities well, and strength was 5/5.
Okay, now I will continue with the specific physical examination. For the inspection, the chest moves symmetrically with each respiration. Frequent barking cough, no skin discoloration and no attachment, no chest wall deformity, no scars, no active veins, so it's okay. And there is lower rib retraction at rest, which is a sign of respiratory distress. And during palpation, there is presence of tracheal tuck. Tracheal tuck means that, as you can see in the picture, the pathophysiology of it, why? Because this patient have croup. So because of inflammation, and then later on there is swelling around the trachea, so the trachea will be narrow, and then the air pressure is lacking of air pressure. That's why the skin is tucked in, as you can see in the picture. You can see the tracheal tuck, or we call also.
No, that's not there. Okay, sorry, you're pointing at the sternum there. Okay, tracheal tuck is in between the. Sini, tengok mine.
I think it's lari sikit.
Here. This is tracheal tuck. Okay, in between the sternocleidomastoid. So this trachea will go in. That's tracheal tuck. Here. I don't have it. Okay, so your photo is not that sternal recession. Okay, if it's recessing from there. All right. Okay.
Okay, thank you. And during percussion was resonant on all lung zones bilaterally. So it's normal. And for the auscultation, there is prolonged inspiratory stridor. No crepitation or ronchi can be appreciated, while cardiac could not be assessed. So only inspiratory stridor. Okay, next. Okay, so based on the history taking and also based on the physical examination, our provisional diagnosis is croup. And because of there is evidence of barking cough, hoarseness of voice, nasal congestion, high to moderate grade fever, and usually it's just moderate grade fever. And there is a lower retraction, which is showing the signs of respiratory distress. There is presence of tracheal tube, prolonged respiratory stridor. Okay, next. So this is the differential diagnosis. Our first one is acute hepatitis. Why? This is supporting evidence because this patient has fever, but then why we exclude this? Because this patient only have low grade fever, whereas in epiglottitis, patient will have high grade fever, and this patient also have hoarse. But then this patient have prolonged inspiratory stridor, whereas in epiglottitis, stridor is just a weak or usually absent. And there are lots more to exclude acute hepatitis because of this patient not appear toxic, and usually it will took only hours, but then this patient took days, which supporting our provisional diagnosis, which is croup. And there is no drooling saliva, no swallowing difficulty, and also okay. And then also, like, this patient still cooperative to open mouth during examination, which is there is no intense barefoot route. And then next one is four-inch body aspiration. This patient also have barking cough and hoarseness. But then why we exclude this disease? Because, and then on how to exclude four-inch body aspiration, we need to do the investigation on later on using the X-ray. There is no absence of truth. There is no drooling, there is no dyspnea, there is no chest pain, and also no monophonic wheezing or absent breath sound on during examination. And also acute. Next one is acute angioneurotic edema. Why? Because this patient also have lip edema and history of allergy. But then why we exclude this? Because there is no urticaria rash, no dysphagia without hoarseness, and also no painful sensation during swallowing. And last one is bacterial tracheitis. Why? This patient also have fever, but then only low grade fever. But in bacterial tracheitis, usually it's a moderate to high grade fever. And also hash rhino. This patient has hash rhino, cough, and rib retraction. And why we exclude this patient not appear toxic? Usually in bacterial tracheitis, we look toxic and very ill. Okay, next. And for the investigation, the diagnosis is most importantly made on clinical grounds. A routine neck radiograph is not necessary unless the diagnosis is still unclear and we want to exclude foreign bodies, so we need to do chest X-ray. As you can see in the photo given, usually patient with croup will present with steeple sign. As you can see in the photo, like there's a steep sign in the windpipe, so you can differentiate with the normal. And the next one, this one is using AP radiograph, and if you do the lateral neck radiograph, we can see distended hypopharynx and also subglottic narrowing. Okay, next. Okay, for the management, okay, there is assessment of there are two assessment of croup, which is Wesley and Wagner. But when I refer to CPG, I think Malaysia use Wagner. There are three: mild, moderate, and severe. For mild, patient should have stridor with excitement or at rest with no respiratory distress. And for moderate, stridor at rest with intercostal, subcostal, or external recession. So this our patient have moderate severity. And for severe, patient must have stridor at rest with marked recession, decreased air entry, and altered level of consciousness. And for pulse oximetry, it's helpful but not really essential. And arterial blood gas is not helpful because the blood parameters may remain normal to the late stage, and the process of blood taking also may distress the child. And treatment for viral croup, indication for hospital admission. First one, it must be moderate and severe viral croup. And then toxic looking, poor oral intake, age less than 6 months,
unreliable caregivers at home, and family that live a long distance from hospital and lack reliable transport. Okay, next. Okay, this is the flow on what medications we can give to the patient. So from our patient just now, she's having moderate croup. So need to give dexamethasone or nebulized budesonide because this patient is tachypneic. Dexamethasone and budesonide is a corticosteroid therapy. Okay, this is dosage you can read later on. But if improved, can go to home, but no improvement or deteriorate, can also give nebulized adrenaline at this amount of dosage. Okay. Okay, next.
Okay. Just now, okay, just beware. Okay, that you say that nebulized adrenaline. So, what is the problem with nebulized adrenaline?
Cannot be given to patient with cyanotic heart disease.
Anything else? So if you give it to mild patient, mild croup, so what's going to happen? Suddenly you are a doctor in the, some clinic kesihatan, and suddenly the patient comes to you with croup. You are panicking. You don't have budesonide. You gave adrenaline naps. 1 in 1,000, not 1 in 10,000. Okay. So what happened then?
Causing acute respiratory distress.
But the purpose of giving adrenaline is to open up the airway, open up the upper airway issue. So is there any side effect or problems or that you are anticipating? Okay, beware, because if you giving it to a mild croup, it can have, they call it rebound phenomena. So which means they open up the airway briefly and then suddenly after that it close back. So nebulized adrenaline should be given in the hospital only. If you're giving it to mild croup, the patient needs to be admitted. Despite it looks okay, or the patient looks fine, and suddenly you don't know what's going to happen in the next 20, 30 minutes when you discharge the patient. The patient might gone back to where he was before, which is narrowing in the upper airway and leading to respiratory problems. Okay, so whatever you're going to give in the future, make sure you know the side effect of the drugs that you're going to give. All right, don't just give it without knowing the side effect. All right. Okay, next one. I have another meeting at 3, so I need to finish it at 2:45. Okay, please.
Okay, basically this one is just like additional info you can read later on. Basically just now I explained about corticosteroid therapy. There are other which like nebulized adrenaline, oxygen therapy, antibiotic, and also intravenous fluid. You can read the details later on your own. Okay, next. Okay, that's all from us. Thank you.
Okay, right. Okay, next one.
Alright, my name is Jazin and I will briefly explain about the respiratory distress syndrome case. So our patient is Daniel, 1 day old, male. He is Malay and live in Kubangkran, Kelantan. The informant is the mother. So for the chief complaint, patient admitted with respiratory distress and low birth weight requiring preterm. So for the history of presenting illness, there are rapid breathing, 1 hour prior to the admission, and that it also associated with noisy breathing during expiratory. And then patient also have nasal flaring, which 1 hour prior to admission too. For systemic review, it is unremarkable, and then this is the first time patient got hospitalized. For pediatric history, patient born in Hospital Kota Baru. The birth weight is 1.2 kg, which is low birth rate. For the maternal history during delivery, it is normal vaginal delivery with prolonged rupture of membrane more than 18 hours. And then period of gestation is at 30 weeks, which is patient is preterm. And then feeding history, patient is breastfeeding. For the family history, it is a non-consanguinity marriage, no family history of malignancy, TB, or heart disease. The other siblings are well, which is our patient is the third child out of the 3 siblings. The mother has 6-year-old son and 2-year-old daughter. For the social history, the father is a businessman, the mother is a housewife, and there is no pets in the house. During physical examination, during general examination, patient is pale and then they're ill appearing. They show signs of respiratory distress such as expiratory grunting, intercostal and subcostal retraction. There is no other obvious deformity seen and no muscle wasting. For the vital signs, the heart is 145 beats per minute, which is normal but higher than the average. The average will be 125 beats per minute for newborn. Respiratory rate is 60 beats per minute, which is tachypnea. The partial saturation, oxygen saturation for patient is 68%, which is very low. Auxiliary temperature is 36 degree, which is hypothermia. For the anthropometric measurements, the height is 39 cm, head circumference is 29 cm, weight is 1.2 kg, and the ponderosa index is 2.02, which is patient is underweight. The examination of hands, face, neck, and legs is normal or unremarkable. And then for the next is specific examination. Next slide. This is a respiratory system examination. So during inspection, the chest moves symmetrically with each respiration. There are also mild to moderate intercostal and subcostal retraction can be seen. There is presence of nasal flaring. During palpitation, patient cannot follow the order, so we cannot assess the tactile parameters. For percussion was resonance on all lung zone bilaterally. And then during auscultation, it is normal vascular breath sound equally on both sides and clearly. There's also occasional grunting during expiration. Next slide. So for the diagnosis, the provisional diagnosis is acute respiratory distress syndromes, which the supporting evidence is because the patient is preterm birth, which those infants that are between the 28 to 32 weeks have a 60% risk on getting the acute respiratory distress syndromes. The onset is also near the time of birth, and then there is other sign of respiratory distress such as rapid respiration, chest retraction, nasal flaring, grunting, and patient pale in looking. For differential diagnosis, over here we have transient tachypnea of the newborn because of the respiratory distress, but it usually happens when patients are more mature. And then for pneumonia, there is a respiratory distress and then preterm and prolonged rupture of membrane, and it also happens soon after the onset is soon after birth, but there is no history of maternal GBS infection, no abdominal distension, and no pulmonary hypertension. For cyanotic congenital heart disease, the supporting evidence is again respiratory distress, but there is no heart murmur can be heard, no cyanosis. The symptoms is usually milder, and patient will have persistent hypoxia even though we give the supplemental oxygen. So for the investigation on this patient, during the chest radiograph, there is light lung appearance, which indicate collapse of lung tissue. We also call it as ground glass appearance. The ABG result is respiratory acidosis. Partial pressure of carbon dioxide is 55 millimeter mercury, which is elevated. And then partial pressure of oxygen is 70 millimeter mercury, which is low. For the oxygen saturation in the patient is 68%, so less oxygen spread through the body. So the management for our patient, we need to place infant in incubator to avoid hypothermia and to minimize the oxygen consumption. So the temperature maintained is 36.5 to 36 degrees Celsius. The calories and fluid will provide it intravenously adequately. For oxygen therapy, we should give continuous positive airway pressure to prevent the lung collapse due to the surfactant deficient. And then if it's patient fail to respond to the less invasive method of ventilation, we can give endotracheal intubation and mechanical ventilation. Surfactant therapy will be given to reduce the mortality and morbidity risk. And then the prevention is before this all happen. If the mother have the risk of preterm birth, yeah, and then mother need to be given corticosteroids before 34 weeks of gestation to prevent preterm labor, and then to also give the increase in the lung maturation to reduce the incidence of respiratory distress syndrome in infants. Okay, I think that's all for the respiratory distress syndrome. The next is the general assessment of respiratory distress and pediatrics. So these are the pediatric assessment triangle. So we need to look at the appearance, the work of breathing, and the circulation. For the appearance, we need to listen to the patient voice, whether the patient is irritable or like kind of like can talk a bit and then suddenly get irritable due to the maybe discomfort. And then patient look ill or lethargy. And then for the work of breathing, you can hear abnormal breath sounds and then abnormal positioning. Patient might like lean forward to breathe, and then chest retraction and also nasal flaring. For circulation, we can look for the pallor, mottling, which is reddish spots in the skin, and then sinuses and also bleeding. This is the approach to the pediatric patient in respiratory distress. So again, the triangle that been discussed earlier, if patient all have normal appearance, normal work of breathing, normal circulation, then there is no respiratory distress. If patient have...
Jasmine, can you focus on assessment, please? I mean, like that's that's when you want to intervene. Okay, I mean, what are the assessment? How do you qualify? I mean, each of the case early on. So we have a case of A, asthma, B, croup, or the group you stated how you want to divide, whether this is a mild, moderate, severe croup. But how do you universally or collectively make the decision in order to determine whether it is mild, moderate, or severe? Because why is, do you have how you going to do it?
Yes, go to the next slide.
Okay, yeah, sure.
Next slide again. All right, here. So these are how to differentiate whether it's mild, moderate, or severe. So firstly, during the behavior, if patient still can able to talk normally, it is mild presentation. If it's patient sometimes get irritable, and then sometimes patient can talk, but there is some limitation when we talk to the patient, then it is moderate. But then if patient like looks lethargy and the patient increase in irritability, and then there are limitation of ability to talk or patient unable to talk due to shortness of breath, it is severe. And then for tachypnea, if it's normal or mildly increased, then it is mild. But it is you can see the increase in respiratory rate, then it's moderate. But
why do they say it's normal? Normal is normal lah. Normal is not tachypnea. You get what I mean?
Yeah.
So don't say normal is normal, okay? Normal is normal lah, okay? So it's not respiratory distress. And it's not respiratory distress at all. So it's normal lah. So mild respiratory distress may be related to mild tachypnea. That's I accept that, okay?
Okay.
Not normal tachypnea. There's no term as normal tachypnea.
So can I say it's like above the average?
If the respiratory rate within the normal limit, you don't say it's tachypnea.
Oh, okay, I got it.
And you don't say this is respiratory distress. Therefore, isn't it? So there's no point of saying it's normal lah. Okay.
Okay, it's normal.
So don't say this is tachypnea, which is normal. What do you mean by that? The term itself is very confusing to me. Normal. Yeah. So please make sure if it's mild respiratory distress, it might present with tachypnea only. Mild tachypnea, okay lah. Okay. Which means outside the normal respiratory rate. If it's in the normal respiratory rate, it's not respiratory distress. Therefore, it's not tachypnea lah, basically, isn't it? It's not tachypnea. Yeah.
All right. Thank you, doctor. And then if there is a significantly increase or markedly, if it is significantly increased in the in the heart rate, then in the respiratory rate, wait, tachycardia, yeah. Yes, in the respiratory rate, then it is severe. For the sign of increase in of breathing, whether it is patient have retraction, which is intercostal, suprasternal, or costal migraine, which is chest retraction. The patient there is accessory muscle used during breathing. This is nasoflaring, and then patient, the posture is like leaning forward. If there is none of this, then it is mild, or if it is mild to moderate retraction and accessory muscle use, then it is moderate respiratory distress. And then if it is marked increase in accessory muscle use with prominent chest retraction, then it is very severe.
Yeah. Just beware, okay? I'm not saying. If you have silent chest, what do you reckon?
Silent chest. For this silent
asthma. If you have silent chest, asthma. Have you ever heard asthma? Asthma with silent chest, is it?
I've never heard about the silent chest, but that I Google, it's a dangerous sign.
Tahu pun. Okay, so whatever it is that's what I want to highlight here, mild is only maybe tachycardic and tachypnea. Severe, the most important thing is what? The most important thing. When oxygen saturation is dropped, when you are cynosed, what's going to happen to you? You are going to be unconscious lah, okay? Unconscious. ECS will be low because oxygen supply of oxygen requirement. You need oxygen requirement, but your oxygen in the body is low, so therefore you're going to lose your consciousness. So in a case where we're talking about respiratory here, okay, we're not talking about any other systems. So we're talking about respiratory. So in any case, I know you want to assess whatever lah, mark recession, how mark is marked between these two. It's very difficult, isn't it? How do you say moderate recession? I don't know. You need to be much more objective in that. Okay, so if there is any is a child tachypnic or silent chest, and then there is an element where oxygen saturation in the body which is low, leading to unconsciousness, leading to drowsiness. You know, this is related to respiratory problems. This is severe. Why is it important, all this differentiation? If it's severe, what are you going to
do? Give immediate treatment.
Not immediate treatment, intubation. Okay?
Oh, yeah, intubation.
Intubate lah, okay? If you think that this child is, losing consciousness, because of respiratory problem, you've got to intubate the child. So you cannot wait. So knowing the differentiation between these three is vital for you to decide on your path for treatment. Okay? So that's why I'm asking you to do this, because this exercise will make you aware that what you need to do in order to determine which one is sick and which one is not sick. I'm not saying sick or not sick, but which one needs an oxygen, which one doesn't need oxygen, which one needs full attention, which one needs ventilation, etc. So this is important, okay? All right, okay, that's fine. Next, finish.
Oh yeah, that's all.
Okay, we are open to discussion to these three or whatever. How many of you? Is there any question that you want to highlight or tell or discuss to the presenter? Guys, anything? Quiet. So everybody is understood already on the topics, is it? Resume. There's no question then? Needed more reading, okay? The topics is only covered one, lower respiratory problems, as I said, it's not covering everything. 2 upper respiratory problems, and the 3 one is lower, but then like it's more into a severe form for neonates, and because of the surfactant deficiency, because of the prematurity and etc. So I think it's just only 3 spectrum. I cannot emphasize that. Although this is just only a gist of what you've seen, but the presentation style of your presentation needs to be improved a little bit. Okay, the more you present, the more better you become. Number 2 is that information in the presentation. I mean, I've critiqued some of your presentations. Some of you may not get my criticisms, but the purpose of that critiques is to improve on the presentation styles. Nonetheless, okay, it's not to demotivate, neither to shaming you in front of your friends, but preparedness of your presentation and how you could regurgitate those information when you're presenting. Your presenting style need to be improved when you're coming to year 5 later. So I think those are the things that you need to be improved on. I hope some of the things that we discussed are things which is assessment, mild, moderate, severe respiratory distress. You need to understand the mechanism behind it, the pathophysiology. We are coming here to pediatrics. When you're coming here to pediatrics, it is a must that you understand what happened to the child in order to explain it pathophysiologically, and then you will be able to understand the treatment pattern, treatment or management that you want to give to the patient by understanding the pathophysiology behind it. Okay, so I think that's all. Then I have to go and pray a little bit, and then after that, 3 o'clock I have to go to meet up with somebody. All right, so I think we finish it here again. Okay, is that all right? Okay, thank you. See you then. Thank you.
Thank you.
Thank you, Doctor.